Now that we have reviewed the basics of the mycobacterial cell, let's discuss the individual therapies used to treat these bacterium. The first class of drugs we'll talk about are the rifamycins, which include rifampin and rifabutin. These drugs work by inhibiting the RNA polymerase found in these organisms. By doing so, they decrease the mRNA production and therefore reduce bacterial proteins and kill the bacterium. It is used primarily to treat Mycobacterium tuberculosis as part of the RIPE therapy. It is also used to treat Mycobacterium leprae when it's combined with dapsone. Rifampin is rarely used by itself when treating Mycobacterium because the RNA polymerase can mutate rapidly and make the rifampin ineffective. The only times it is used as a monotherapy is for prophylaxis against Neisseria meningitidis and Haemophilus influenza in children. A good way to remember the 4 important things that are likely to be tested on USMLE Step 1 about rifampin is to remember the 4 R's. R number 1 is that rifampin, or the rifamycins, are RNA polymerase inhibitors. The second R is that resistance to the drug develops rapidly when it's used as a monotherapy. The third R is that it can cause red-orange body fluids that can be very worrisome or scary to the patient. And finally, the fourth R is that it revs up cytochrome P450. Do you remember what that means? Well, as discussed in the other lectures, P450 is responsible for metabolizing drugs. Rifampin activates this P450 system and results in increased metabolism of certain drugs, causing them to have lower serum levels in the blood. Isoniazid is the next drug we're going to talk about, and it is the key drug used in the treatment of Mycobacterium tuberculosis. Do you remember its mechanism of action? Isoniazid inhibits the synthesis of mycolic acid. Mycolic acid is a main component of the Mycobacterium cell wall, and it is unique to Mycobacterium. Like we mentioned earlier, isoniazid is one of the main treatments for Mycobacterium tuberculosis. It is used for the latent, and it is used to treat the active form as part of the RIPE therapy. In order to be effective, INH requires conversion to its active form by catalase peroxidase. The catalase peroxidase is encoded by gene CatG. So INH goes through the product of CatG to become activated. Mycobacterium tuberculosis can become resistant to INH when it mutates its CatG and has no catalase peroxidase. The organisms that do not have CatG are unaffected by isoniazid because isoniazid has no way of becoming activated. It is important to remember that INH has a number of clinically important side effects. Specifically, it injures nerves and hepatocytes. Do you know how we can prevent the toxicity associated with the neurotoxicity? We can prevent the neurotoxicity or the peripheral neuropathy caused by isoniazid by co-administration of vitamin B6. Very good. Another thing to remember is that INH can also cause a drug-induced lupus, and it is an inhibitor of cytochrome P450. Rifampin and isoniazid are the 2 most important tuberculosis drugs for Step 1 because really there is the most testable information on them. The last 2 lower yield drugs in the RIPE cocktail are pyrazinamide and ethambutol. The mechanism of action of pyrazinamide is not well understood. What is understood though, it is that it is particularly effective at low pH and it's effective in the phagolysosome of the macrophage. This is macrophage. So, by remembering this mechanism may help you remember that macrophages are the key cell involved in fighting TB infection. Remember, the macrophage forms epithelioid histiocytes, which then form the granulomas that are important to fighting tuberculosis infection. The main toxicity of pyrazinamide is hepatotoxicity and hyperuricemia. When we think about hyperuricemia, can you remember an important diuretic that also causes hyperuricemia? Those would be the thiazide diuretics. So now that we've talked about 3 of the 4 drugs used in the treatment of tuberculosis, can you tell me a toxicity that is common to 2 of them? That would be the hepatotoxicity as seen with pyrazinamide and isoniazid. So you can imagine when you're treating a patient with say active tuberculosis, that these patients would suffer some possible hepatotoxicity and some liver inflammation. So with this in mind, as your patient's doctor, how would you monitor the hepatotoxicity? What would you look for in the blood? Well, you can look for and look at AST and ALT levels, which are enzymes that are mostly specific to the liver. If you have increased levels of these enzymes found on a complete metabolic panel or a basic metabolic panel, you would understand or you could see that your patient's liver is becoming inflamed. So in order to make sure your patient's liver is not becoming too inflamed or not becoming affected, you would order these AST and ALT levels every few weeks to monitor. Ethambutol is the final drug used in the 4-drug therapy against active tuberculosis. It is the E in the ripe mnemonic. Do you remember the mechanism of action of ethambutol? The drug works by blocking the enzyme arabinosyl transferase, which is responsible for producing arabinogalactan. Without arabinogalactan, the mycobacterial cell cannot survive. The unique toxicity associated with ethambutol, and probably one of the most important things to know for step 1, is that it can cause an optic neuropathy that leads to red and green color blindness. So look at this image real closely. Can you see a number in this image? Well, there's a number 37 in this image. Individuals that suffer from red-green color blindness or ethambutol-induced optic neuropathy are going to have difficulty seeing this number 37 here in this image. Now time for a flash quiz. Do you remember how isoniazid and rifampin affect the cytochrome P450 system? Are they inducers or inhibitors? Well, remember, isoniazid inhibits cytochrome P450, while rifampin induces or revs up cytochrome P450. Remember the 4 R's associated with rifampin. An important way and a nice way we can remember that isoniazid inhibits cytochrome P450 is to look at I in isoniazid and remember that it inhibits. Can you remind me of the 3 clinically important mycobacterial organisms? That would be tuberculosis, avium intracellular, and leprae. Very good. And do you remember what drugs are used for prophylaxis against Mycobacterium tuberculosis or Mycobacterium avium intracellular? Isoniazid is used for prophylaxis against tuberculosis, and azithromycin is used for prophylaxis against avium intracellular. Very good. Now we're going to move on to a section in first aid that will highlight some other diseases where we use medications for prophylaxis. Here's an image of a cardiac ventricle at autopsy. What do you notice about the valves? Do you see a problem? Well, we can see here some vegetations found on the mitral valve. These are indicative of bacterial endocarditis. Do you remember the most common bacterial organisms that cause bacterial endocarditis? Well, there are a number of them, but the most important ones are Staph aureus, viridin strep, strep bovis, and enterococci. In order to try and prevent endocarditis in susceptible patients, a penicillin drug, such as amoxicillin, is typically administered before high-risk procedures, such as a dental procedure, for instance. Moving on, what if this image showed up on step 1 and said it was recovered on a smear of a 19-year-old female who was presenting with purulent vaginal discharge? What would be your diagnosis, doctor? Well, if you look closely at the image here, do you notice these diplococci right there? What do you think those are? This is an image of Neisseria gonorrhea. Very good. This gonorrhea is causing a purulent cervicitis in our make-believe patient. And so how would you treat her? Well, in this case, to treat, we would give ceftriaxone. And what would we do in addition to treatment? Say, what can we give for prophylaxis against gonorrhea, say, in her partner? Well, for gonorrhea exposure, or for an individual that is sexually active with another individual who's found to have gonorrhea, we can give ceftriaxone to try to treat him or her for a suspected gonorrhea infection. Now say we're at our clinic and we have a patient that comes in who continues to have pain and burning with urination, some tenderness above the pelvic bone, and maybe some occasional fevers. What infection am I describing here? Yeah, I'm describing a urinary tract infection. Very good. So say a female, usually a female or maybe a male, kept getting recurrent urinary tract infections. Is there anything we could give them to prevent them from continuing to have them? Well, yeah, we can give them trimethoprim, sulfamethoxazole. Going back to discussing these two medications, do you remember which enzyme is inhibited by sulfamethoxazole? That's dihydroteroate synthase. Very good. How about trimethoprim? Trimethoprim inhibits dihydrofolic acid synthase. Very good. Now say a teenager presented into your emergency department with a terrible headache. He was found to have a fever, and on a physical exam his neck seemed a bit stiff. What are you immediately concerned about with this constellation of clinical findings? Meningitis. Very good. And in this age group, which bacteria would you be particularly concerned for? Neisseria meningitidis. Very good. Now imagine he was found to have Neisseria meningitidis and he lived with some roommates in a dorm. Could you give his roommates anything to prevent or prophylax them from getting the same disease? Yes, absolutely. We can give them ciprofloxacin or rifampin to block and to prevent meningococcal meningitis in patients that may have been exposed. Ampicillin is given to pregnant women who are found to have group B strep in their vaginal canal. Do you remember why it is important to treat pregnant women who have group B strep? Well, because during birth, this bacteria can be contracted by the baby and it can cause a fatal meningitis. Very good. So thinking back to our section on penicillin drugs, do you remember if ampicillin is beta-lactamase sensitive or resistant? Remember, it is sensitive to beta-lactamases when it's given on its own, but commonly we combine it with clavulanic acid, a beta-lactamase inhibitor. Very good. Now, can you tell me the most commonly sexually transmitted infection? That's chlamydia. Very good. And what other sexually transmitted infection is commonly associated with chlamydia? Gonorrhea. Very good. So during birth, pregnant women that are infected with gonorrhea can actually pass the bacteria to the newborn. And do you remember in the baby or in the newborn where gonorrhea can cause and affect or harm the baby? It can actually cause disease in the conjunctiva of the eyes. So in order to prevent a severe conjunctivitis or gonococcal conjunctivitis, we give erythromycin ointment to the babies. So if you've ever worked in a newborn nursery, you should always see, or you should usually see, erythromycin ointment in the baby's eyes. After surgery, a common complication can be a wound infection. And do you remember what the most common bacteria that causes a wound infection? Staph aureus. Very good. Right before an incision is made in the operating room, cefazolin is given to prevent a post-surgical infection of Staph aureus. Thinking back to our cephalosporins, which generation cephalosporin is cefazolin? It is a first generation cephalosporin. Very good. And finally, penicillin G can be given to prevent rheumatic fever in order to prevent another episode of strep pharyngitis. And finally, one more, penicillin G can be given to prevent syphilis in susceptible patients. Do you remember what bacteria causes syphilis? Remember, it's a spirochete, Treponema pallidum. Very good. So now we've discussed some medications that are used as prophylaxis to prevent individuals from getting these certain conditions. Patients with HIV infection really benefit from prophylaxis against some very serious diseases. We do not give everyone with HIV prophylactic medication. Rather, we give them medication based on their CD4 T cell counts. So continuing on the theme of antimicrobial prophylaxis, patients with HIV really benefit from prophylaxis against some very serious diseases. We do not give everyone with HIV prophylactic medication. Rather, we give them medication based on their CD4 T cell counts. So do you remember which infection that HIV patients are at risk for if their CD4 count goes below 200? Well, we're concerned about PCP or pneumocystis pneumonia. And what medications can we use to provide prophylaxis against PCP pneumonia? We can give trimethoprim sulfamethoxazole. Very good. So how about in HIV patients with CD4 counts less than 100? What opportunistic infections are these patients at risk for? In addition to PCP pneumonia, they're at risk for toxoplasmosis. And can you remember what causes toxoplasmosis? It is caused by Toxoplasma gondii, a protozoa that can cause intracranial calcifications in addition to a dangerous meningitis. And do you know what medication we can use to provide prophylaxis against these two infections? We can give trimethoprim sulfamethoxazole. Very good. So finally, in patients with CD4 counts of less than 50, what kind of organisms are we concerned about? Well, in addition to being at risk for PCP and toxoplasmosis, we're concerned for Mycobacterium avium intracellular, or MAC. And do you remember what medication we can use as prophylaxis for MAC? We can give azithromycin, a macrolide. So it's very important when we're taking care of patients with HIV that we follow their CD4 counts and administer these prophylactic medications at appropriate times so that our patients do not get these serious diseases.